Hello everyone, it's a great honor for me to be here, and I've seen many old friends. And as you can see, I've just in a short break in 2 operations, and time is precious. And today my topic will be tailored by parts based on blood flow analysis in middle cerebral artery territory in Myomy disease. And my name is Yujun Liao, and this is my colleague. And
Hello, everyone. I'm so pleased to be here with you on behalf of Professor Binshu and my senior, Dr. Liao. I need to thank you for inviting us to join this webinar. My name is Mohammed Helmy. I'm a master degree student here at Khwashan Hospital, and so happy to be with you here today.
Thank you so
and
much, Dor. Yes.
Yeah, and firstly, a short introduction of ourselves. And this is where we are from. And we have 3 campus in our hospital, and we come from a huge family. And we have about 150 neurosurgeons in one single department. And we from Shanghai, China. And this one, can I see it?
Yeah.
This one is our boss, Professor Xu Bing, and we are with idols all around the world. And this is when we celebrating 9 cases of Myomy bypass in one day. And now I will begin my topic. And it's common sense nowadays, and cerebral revascularization is the only effective way to treat Myomy disease. And we will be very glad to see the result. And we can see the STA is getting larger, and which can perfuse almost the totally MCA territory. And sometimes the diameter of the STA can increase to more than 3 millimeters, and this is good result. But we will be very disappointed when we see this kind of follow-up. As you can see, the bypass is patent, but with shrink STA, and of course, if clinical effect won't be so good. But why there are difference between these 2 kind of patients, and how this happened, and how to get a good result in SCA MCA bypass. And we working on this topic several years, and nowadays we figure out maybe there's 2 important things during the operation of SCA MCA bypass. And the first one is to perform the anastomosis. And after open the dural, we can see several artery which may be candidate for anastomosis, but which one would be better? So this is the first question. And the second question is, if we select a recipient artery, but in which direction is better? Like this patient, the blood flow comes from proximal to distal. But this, so which direction should we perform the anastomosis? So I will talk about these two things next. And now let's go to the first one. After we open the dural, where to anastomosis? And let's take a short look at the equation, Pursuer law in the left side. And it seems very complicated, but we only need to know 2 things. The first one is the Q, means the blood flow in the STA. And the other one is the delta pressure. And delta pressure is the distance between the donor artery and the recipient artery. And as you can see, the delta pressure is the only thing we can control in the operation. And the delta pressure is the only driving force of the blood flow of the STA. So we believe during the operation is the key point to make sure the delta pressure is positive, and the delta pressure, the higher the better. And it's very complicated to talk about hemodynamics. So let's talk about real case in the operation room. And when I was the operator, after open the dural of this patient in the right side, which is angiogram, and I confused B point and A point. Which one is better for anastomosis? My boss told me the A point will be better, but why? And he said point A can make a bigger and larger delta pressure, but why? Let's see this. And still this patient from B point to A point, and the pressure distance on A point is equals pressure of STA minus pressure in A point, and similar to B point. So because the A point is in the downstream of the blood flow, so the pressure in A point is smaller than pressure in B point. So we speculate the A point would be better for anastomosis, but this is a hypothesis. So we conducted clinical research, and it's like this. In a case series, we performed double-barreled bypass. As you can see in the left side, double bypass in both A point and B point. And this is the chunk of STA, and we place a detector in the trunk of STA. And after we occluded the A point, we can measure the pressure in B point. And in the other way, we can measure the pressure in the A point. And in this way, we can measure the pressure in A point, B point, and the pressure of STA. And it's very complicated, but the result is interesting. As you can see, A point is in the downstream of the MCA blood flow, and the pressure is about 21, and the B point pressure is about 36. So the clinical study confirmed our hypothesis, and actually it's true. A point, because it's in the downstream of MCA blood flow, so it's better for anastomosis. And this is our clinical research. And but as you know, in myeloma disease, not everyone got this blood flow direction. In some cases, we can see blood flow direction with retrograde direction like this one, since the MCA is totally occluded. So the MCA territory was perfused by collaterals from posterior circulation and sometimes from ACA. So in this kind of patient, the B point will be the downstream of the blood flow. So the B point in the right side will be a better choice for anastomosis. So this is the first part of of my topic today. Recipient artery in downstream of MCA blood flow is better for anastomosis. Now we know where to bypass, and the second question is to how to bypass, how to select the direction of the bypass. And this is a picture by Professor Bankochi from Germany, and he already talked about the blood flow direction, and it's common sense according to basic physics knowledge. And we should make the bypass flow and initial flow in the same direction. That will be better. But is it really true in the real world? We also conduct a retrospective study of our early cases, and we enrolled about 50 myeloma cases around 10 years ago. And these are our early cases. And after chart review and review of the angiogram, we divided the cases into two groups. And one is co-direction and the other is counter-direction. The co-direction means the bypass flow goes in the same direction with the initial blood flow in MCA territory. And the counter-direction group means the bypass flow goes in the opposite direction of initial blood flow. And we analyze the clinical result, and we find the co-direction group during the early follow-up and the 6-month follow-up. The co-direction strategy can get a higher blood flow of the STA and with lower resistance of the STA. And so the co-direction group will have a lower risk of a transient neurological deficit and the lower incidence of watershed shift in ICG video angiogram. We show you angiogram in our operation. As you can see, there's blood flow competition in this area. And we can observe this kind of phenomenon more often in counter direction group of patient. And during time, we will skip this part. And we also performed a long-term follow-up with angiogram, and the result is that the co-direction group will get a larger STA and a larger feeding area compared with the counter-direction group. And this is a typical follow-up angiogram of counter-direction group. We can see the bypass is patent, but the blood flow is not so good. But in the co-direction group, we can find the blood flow very well, which can perfuse almost all of the MCA territory. So this is our conclusion, and how to get a good result during the STA-MCA bypass. And the first one is to weld to bypass. And our conclusion is that recipient artery in the downstream of MCA blood flow is better for anastomosis because it can provide a larger delta pressure. And the second question is how to perform the anastomosis. So our conclusion is that we try to make the donor artery and the recipient artery in the same direction. So this is our conclusion of this topic.
Thank you so much, sir.
Thank you very much.
Thank you so much, sir. The honor is huge, sir. Thank you for addressing such an important topic, especially for us in many parts of the world. Moyamoya disease is not very common, so most of us do not even have a very good idea of about even the surgical options. So thank you so much, and this